Assalamualaikum and a very good morning to all. Welcome to University Malaya's Breakfast at FOM. My name is Dr. Sharifah Farida Said Umar, and I am the head of Infectious Disease Unit in UM. So World AIDS Day, which is celebrated yearly on the 1st of December, brings together people from around the world to raise awareness about HIV/AIDS and demonstrate international solidarity in the face of the pandemic caused by the HIV infection. It is also to remember those who have succumbed to this disease. In conjunction with World AIDS Day, the ID unit is happy to be given the opportunity to host today's breakfast at FOM session. So the theme of our forum today is the fight against HIV. Are we winning? We hope to discuss the latest updates in the HIV epidemic, HIV prevention, and efforts in reducing stigma and discrimination. In the fight to end AIDS by 2030, every healthcare worker has a role to play getting HIV to zero. Zero new infections, zero discrimination, and zero AIDS-related death. So let me begin with introducing to you our four wonderful panelists, who also happen to be my dear colleagues and friends. First and foremost, Professor Dr. Adeeba Kamarulzaman, who really needs no introduction. Prof. Adeeba is a senior consultant in infectious disease and the person who set up the UMMC's ID unit upon returning from her ID training in Australia. Suffice to say that unit has grown and flourished over the years. She's also the pioneer of Cheeria UM, which is a center of excellence in research in AIDS. She is currently the president of the International AIDS Society, the first from Asia. We also have with us Associate Professor Dr. Raja Iskandar Azwa, who is also a consultant ID physician with a special interest in HIV medicine, especially with regards to preventing HIV prevention with PrEP. He joined the unit after completing his training in the UK and is currently the lead of HIV-related services in our unit. Iskandar is also the honorary secretary at the Malaysian AIDS Council. Next, we have with us today Dr. Wong Pui Li, another ID physician in the unit. As we get better at treating our patients, we see them growing older with the disease. Therefore, there has been a lot of research related to this. Pui Li has a special interest in HIV aging as well as stigma and discrimination. Last but not least, we have Sister Punita, who is not only the sister of Infectious Diseases Ward, she's also a certified HIV counselor in UMMC. So without further ado, let's get started. Let me start by giving you a snapshot of the current situation of HIV in Malaysia. Okay. So as you can see from the graph here, from the beginning of the pandemic of since 1986, we've seen a drastic increase in number of cases up to the turn of the millennium. With measures such as harm reduction, the numbers have gradually gone down. But unfortunately, in the past decade or so, there has been a plateau of number of cases. And this is mainly driven by the new infection from homosexual transmission. For us to get to zero HIV by 2030, this is the target to get 90% of those with HIV diagnosed, 90% of them on treatment, and 90% who are on treatment virally suppressed. And this is the report card for Malaysia in 2018, where we are good at diagnosing people with HIV. However, there's still a gap on putting them on antiretroviral therapy. But when they are on antiretroviral therapy, they do become virally suppressed. So I would like to start today with the question to Prof. Adeeba first. Prof, so with the amount of experience that you have in this field, how do you see the HIV epidemic evolving over the years and years to come in UMMC, in Malaysia, regionally, and also globally? Could you explain the plateau and shift in transmission mode that we are seeing in Malaysia? And is this shift unique just to Malaysia, or is it also seen globally?
Okay, thanks, Farida. Good morning, everyone. Good to see you all at this breakfast at FOM. So let's start with Malaysia. I think from the graph that you showed, we had a peak of infections back in the late 90s, early 2000, after which we managed to convince the government to implement the needle syringe program and the methadone program amidst a lot of pushback from the community. But what it managed to do, as we expected it to do, it was to drastically, as you can see, reduce the number of new infections as a result of sharing of needles and using unsterile equipment along with the methadone program. So from seeing an annual new infections of about 4 to 5,000, we now are down to, I think, 300 or so cases a year. And I think, if nothing else, this illustrates if you let science guide your policies, it tends to work, particularly if you implement it properly. Regionally, so I haven't finished the Malaysian story. The Malaysian story, then the plateau that we're seeing, like Prof. Farida said, the switch then is to more sexual transmission, and largely amongst young people and men who have sex with men. Which is also a pattern that we're seeing around the region. In Asia and the Pacific, unfortunately, we're lagging behind compared to the rest of the world in reaching those 90-90-90 goals. And 98% of infections in Asia and the Pacific are from what we call key populations. So MSM, people who use drugs in other countries, and transgenders, sex workers, but MSM has been the concern in the region. Globally, although we have seen tremendous improvement over the years, particularly in terms of mortality, with the scale up of antiretroviral treatment. Sadly, like what we heard yesterday in all the speeches around World AIDS Day, we probably will not meet the 2030 goal to end AIDS. We were already lagging behind before the COVID pandemic. And now, in the last year, COVID has disrupted many HIV prevention and treatment services. Nevertheless, I think there are a lot of things to be positive about, and I think Iskandar is going to share the advances around prevention. And well, we've got wonderful treatment. We've got drugs, antiretroviral treatment that can really make a difference. If someone is on treatment, they can truly lead a normal, productive life. So much so they now we run into problems with aging. So I think we're lagging behind both in Malaysia and in the region, but we have all the tools to treat and to prevent. So we just need to work harder.
Thanks for that, Prof. I think you've been around for quite a while and you've seen all the ups and downs of HIV prevention. I remember the days when you were really advocating for harm reduction. It's wonderful to see that reduction in numbers after it was implemented, and it's a bit saddening to see the plateau now. And I hope that we do kick into gear as quickly as possible so that we can see that graph going down again. So I'll move on to our next panelist, Iskandar. So Iskandar, in medicine, we always say prevention is always better than cure. And when we talk about prevention in HIV medicine, we hear about terms like treatment as prevention. We hear about U equals U, harm reduction, all these buzzwords. So Iskandar, could you shed some light on all of this?
So good morning, everyone, and thank you for having me at this talk, and happy World AIDS Day to everyone. So over the past decade has been a very exciting time in terms of HIV research, particularly in the areas of treatment and prevention, with global movements such as U equals to U, which I'll expand a bit further, HIV pre-exposure prophylaxis, which I'll also expand further, and access to better treatment regimens, which are more tolerable. I think one of the more exciting movements that have reached sort of global levels is this concept U equals to U, which is probably what Prof. Sharida was trying to sort of allude towards. So U equals to U equals to, it stands for undetectability, equals to untransmissibility, and essentially is the concept that if everybody who's HIV positive gets diagnosed and gets started on treatment and adheres to the treatment, and the viral load, which is the measure of the virus, which is present in the blood, reaches a level below which the assay can no longer detect the HIV in the blood, so undetectable, it more or less renders positive patients non-infectious, and there is zero risk of transmission. Now, so essentially, and I'll just probably just repeat that, HIV positive patients who are on treatment and take their treatment religiously are non-infectious to other people. So they cannot pass their HIV to other people through sexual transmission. This concept largely applies to sexual transmission and doesn't apply to non-sexual transmission routes. Now, so what does that mean to us as healthcare providers? What does that mean to patients? Now, to patients, essentially, it means that they no longer have to worry about being a potential source of infection to other people. And it removes that huge burden from HIV positive patients. I mean, the majority of people, once they get diagnosed, do not want to pass their HIV, want to act in a I guess, in a responsible way of not wanting to infect others. And this removes that burden. What it also does is it also helps disperse stigma amongst healthcare providers and amongst people living with HIV, and sort of bridges the gap between positive patients and those who are HIV negative. We should not be afraid of HIV because people who are diagnosed on treatment are unable to pass it on, and that's very important. Now, the science behind this concept of U equals to U is largely supported by two large observational studies, the Partner 1 and Partner 2 study, a randomized control trial, which looked at more than 125,000 condomless sexual acts in total, where the positive partner was on antiretroviral therapy, and certainly in the observational studies, one of the criteria to end the studies was not to use condoms. Now, you could argue the ethics at the time, how it went through ethics, but because it went through ethics, they were able to show that there was no risk of transmission. Once again, in 125,000 condomless sexual acts, there was no transmission from the positive partner to the negative partner. So that's important, both in terms of numbers and in the message that we're trying to impart. Now, how then do you communicate this to healthcare providers? It's you know, I mean, it's extremely difficult. But what essentially it means is that the surgeon who's operating on the HIV positive person does not need to worry about putting the patient last on the list. It means that the radiologist who's about to scan the patient does not need to put the patient last on the list. We need not be concerned about infection transmission within healthcare settings from people who are on treatment. And we need to celebrate this with both patients, and we need to get this message out. This message has been slow to get out, but it needs to get out. And we should be changing our hospital policies based on this. So other than U equals to U, I'll just briefly talk about prevention. In the past decade also, there's been tremendous successes in HIV prevention in the form of pre-exposure prophylaxis. Now, pre-exposure prophylaxis is a biomedical HIV prevention strategy. So it involves essentially taking either a pill, a vaginal ring, or more recently, an injectable drug to prevent the acquisition of HIV. The evidence base behind this is huge, so much so that in this year, there were 2 studies looking at injectable cabotegravir, which is an integrase inhibitor, a class of an HIV drug. And it's particularly exciting because it now expands the options to women and beyond just oral therapy for those who are unable to tolerate oral therapy. But the problems largely in Malaysia have been thinking about how to access these HIV prevention strategies, because as a country, as a society, we find it very difficult to talk about sex. We find it very difficult to get our sexual education out there properly so that our children can benefit. We find it very difficult to talk about condoms. So how do we then talk about the next steps of HIV prevention, such as PrEP? So I think these are some of the issues that we need to resolve so that we can maximize on the subsequent HIV prevention expanded options that are about to come into the market. But these are essentially very exciting options that are about to come through, and we really, really need to maximize on these options.
Thank you so much, Iskandar. So yeah, it's exciting to see all the science out there. But as you can see, the science is there that elimination of HIV is possible. But I think we are all aware that one of the biggest barriers to achieve this is stigma. We often think about stigma happening in the community where the public discriminates HIV patients, but I think we sometimes fail to acknowledge the stigma that happens within healthcare settings as well. Getting to zero is not just about getting patients in, but having healthcare workers who are willing to provide the services to them. So this brings me to our next panelist or speaker, Pui Li. Can you tell us about stigma in the healthcare settings and how this is hindering our efforts to end AIDS by 2030?
Sure, Ifa, thank you for your question. So I think as you showed earlier in one of your slides, that there's this huge gap in our 90-90-90 target. So we're doing very well at screening and detecting those with HIV, but there's about a 55% gap that the number of people who have HIV, they are not on treatment. And I think that also alludes to what Iskandar was mentioning, that there is science for prevention, there is science for treatment, but for some reason, we're not able to get people living with HIV on treatment and those at risk of HIV access to prevention. So in order to talk about that, we need to know what stigma really means. And stigma itself is seeing someone in a negative light, judging them, as well as devaluating them. And discrimination is the negative action that results from that. And oftentimes, the discrimination and stigma stems from fear of contracting HIV, as well as lack of awareness of how the disease has now evolved and the treatments that are available for it. And people living with HIV, they not only experience stigma because of HIV, they experience stigma and discrimination because they also have discrimination against gender identity, sexual orientation, people who inject drugs, as well as sex workers. And for them, their largest fear about coming to hospital to access healthcare is that they fear the discrimination of being treated unfairly. And this stops them from getting access to treatment, staying in treatment, or even for those who are at risk of HIV to just get access to preventative treatment. So, are their fears, are they founded? So if we look back at healthcare settings and their experiences of stigma and discrimination, we know that not long ago in our hospitals, people living with HIV, when they get admitted, they have a massive hazard sticker on their folders to warn people that they have HIV. The purpose of this, I'm unsure of, but that itself is an act of discrimination. As Iskandar has mentioned, we do have patients who end up getting delayed, their treatment delayed, their investigations delayed, or some people outright refusing to treat people living with HIV. So, all of these are things that we see in our hospitals as well as other healthcare settings. And not long ago, a couple of years back, one of our ID registrars did a study in our hospital as well as another hospital. It's a survey looking at the intention of physicians to discriminate against people living with HIV. It had about a 40% response rate with 500 over responses. Majority of the respondents were physicians, medical physicians, and also majority of them, thankfully, said that they do not intend to discriminate. However, the studies do show that they do express some intention to discriminate. And there is a correlation that the higher their intention to discriminate, the more fear they have towards people living with HIV, the more negative feelings they have towards people living with HIV, and the more they feel that people living with HIV should not get access to good care. And I think that itself is very frightening.
That's so true. Everything that you said, that is so true. And it's really disheartening that we've got the science, we know what we can do, we know things work, we know treatment works, prevention works, but this stigma and discrimination is really, really stopping us from moving forward. And it's also sad that it's also coming from the healthcare workers themselves, who should be up to date with the science and not mix personal opinions with what's good for the patient. So yeah, so that was really eye-opening, Pui Li. So um, I think I'll move on to Punita first. So Punita, thank you for joining us. It's clear that we all have a role to play, and one of the things that we found in the ID unit is that the nurses have a huge and integral role in providing holistic care to patients and also bridging that clinician doctor and patient relationship. So Sister Punita, you are one of our first trained HIV counselors in UMMC. What made you decide to become a HIV counselor?
Good morning, everyone. Um, what makes me to become a counselor? Okay, that is because we can treat the patient in the ward, but I think we are lacking of knowledge and communication with the patients, especially the HIV patients. So I think I need a complete like a course so that I can give my best service for the patients. So that's why I became a counselor.
So empowering yourself so that you can provide
Yes.
better care. That's brilliant. So many listeners today, because this is a breakfast at FOM, so we've got lots of healthcare workers on board, may not be aware of your role as the HIV counselor. Would you be able to share with us a little bit on what you do?
Okay. As a HIV counselor, at the moment we have 5 of them, including me. So the service that we are giving is actually a newly diagnosed patient that we have to do counseling on pre-heart, post-heart counseling and supportive counseling for the patient and the affected family members and the adherence of the heart medication.
Yeah, we do use our, well, not use doesn't sound like a nice word, but we do utilize your services very much, especially in clinic and in the wards. And I do think that your services, you and the other HIV counselors have been tremendous. So my final question to you is, as a HIV nurse counselor, how do you think other healthcare workers who are not trained in HIV counseling could contribute to improving the care we are giving to our HIV patients?
I think first of all, we need to do the continuous awareness for them because as a healthcare providers, I don't think so the other department or unit. I know they have the knowledge of the uh, disease, but um, to to give the best service for our patient is there is a lacking in the awareness about the awareness they have. So they are still like scared to touch the patient, even talk to the patient. So there is where they call the counselor in because they don't think so they can talk to the patient actually.
Mhm. Yeah, thanks for that insight. Um, so we've finished with our first round. I think we can probably there are a few questions here to the panelists, and I think we could probably start with some of them. So Prof. Adeeba, there's a question here. So it says that Prof. Adeeba, you have often said that stigma discrimination is the Achilles heel of our HIV response locally and globally. UNAIDS has recently launched new anti-discrimination targets for 2025. How do you see Malaysia and specifically UMMC coming together to address these new targets in the coming years?
Thanks for the question, Rina. And the HIV movement is very good at setting targets, often targets that are difficult to reach. But I think starting with the 3x5 many years ago, which was getting 3 million people onto antiretroviral therapy by 2005, everyone thought that it was pretty crazy, but it really galvanized the world. And here we are with, I think, more than 37 million people on HIV treatment. So you heard from Prof. Sharifah earlier about the 90 targets, 90 tested, 90 on treatment, and 90 with undetectable viral levels. The new UNAIDS goals, which are even more ambitious, is to make sure that by 20 2025, less than 10 countries have punitive laws, less than 10% of countries around the world have punitive laws and policies. I think maybe UNAIDS didn't quite read the HIV Global Policy Report that was launched the day after the UNAIDS launch of their new goals, because the HIV Global Policy Report states that there are 33 policies and laws that need to be aligned in order for us to achieve the HIV/AIDS elimination goals. Every country around the world has at least one law that would be detrimental to reaching the HIV elimination goals, and many have all fours, which is, laws criminalizing same-sex behavior, criminalizing drug use, criminalizing sex work, and I think it was transgender, the other one. So there are 4 laws, and every single country has, at least around the world, the 85 countries, 91 countries, has these laws, and some, including ours, have all 4 of those criminalizing laws. So it's a tall order, but what are we here at UMMC are doing? When I wear my other hat, I've also been pursuing this decriminalization of drug use to start off with. And we kind of were getting somewhere with it in terms of getting the government to decriminalize personal use. It's going to be a long, long journey, but at least, that D word is being mentioned now. What else can we do at UMMC? So the second 20%, sorry, is it 20%? Yeah, 10%, less than 10% is reducing stigma and discrimination. And you just heard from Pui Li and Sister Punita, that's, we're doing what we can, starting with training our own nurses and doctors in the unit. Charity begins at home. But Pui Li is also involved in a number of projects. We've got an NIH grant for the next 5 years to look at training healthcare workers, at interventions with healthcare workers to reduce stigma using the ECHO project and this really exciting new tool using photo voice. So, and I think this photo voice technique of reducing stigma and discrimination can be used not just for HIV, but hopefully later on mental health, which was also incredibly stigmatized, and for other things. And the third, less than 10% is, you think I would remember all this. Experience gender, less than 10% experience gender inequality and violence. This is in Malaysia, of course, women still have gender inequality and violence, probably not as prominent, but in some parts of the world, this is a huge issue. And so it is something that we definitely need to be aware of and be sensitive to as well.
Thank you, Prof. Adeeba. Yeah, let me open the question. Yeah. So what is the future of HIV for injecting drug users now that the trend has shifted to men who have sex with men? So, yeah.
Okay, so one thing to also know is that, well, of course, the needle syringe program and the methadone program have to continue, because for as long as we have people who are injecting drugs, using heroin, we need those harm reduction programs to continue to prevent them from becoming infected. But the other thing to know also is that the trend of drug use is changing, is going towards methamphetamine use rather than heroin. So especially for younger users, And unfortunately, we don't have the equivalent of methadone or buprenorphine for methamphetamine use. We've got uh, um, some CBT, cognitive behavioral therapy, and motivational, um, you know, what's the word for it? Motivational interventions, and that our psychiatrists that we work with are psychiatrists on, but there's no magic drugs to replace the addiction to methamphetamine. Having said that, we are working with our other colleagues, Dr. Howie from SPM and Dr. An Yi from psychiatry, on a project to these drugs are called in colloquial terms it's called chemsex, but it's better to describe them as sexualized drug use. So we've also got a small, well, hopefully not so small project to look at interventions for people who use drugs for pleasure that has also been associated with increased risk for becoming infected with HIV.
Okay. I think I'll ask the next question to Iskandar. So someone asked, so then is PrEP required for serodiscordant couples wanting to conceive?
I'll probably just define serodiscordant because everybody may not know what serodiscordant is. And so serodiscordant couples are when one partner is HIV positive and the other is HIV negative. And the best and most effective HIV prevention strategy there is to get the HIV positive partner on antiretroviral treatment and get them undetectable. And that in itself should prevent HIV infection if we're applying that U equals to U evidence and science in that particular scenario. When we started out PrEP, generally in clinics, whether it was in UMMC or in clinic kesehatans, a lot of the target population at the time was serodiscordant couples wanting to conceive. And the U equals to U message had not really, it had come out, but it had not really, the level of awareness had not really reached a lot of healthcare providers. And so PrEP was used in a lot of these circumstances, despite the positive partner being on antiretroviral therapy and being suppressed on antiretroviral treatment. Currently, I think myself, anyways, and I do speak for my colleagues as well, is that provided that the positive partner is on treatment, I don't think PrEP is required for the HIV negative partner, but these circumstances are difficult. These discussions around losing the condoms in a relationship when you're trying to conceive are very difficult to sort of have at times, and for people to sort of embrace the U equals to U message. So in the event that the HIV negative partner still wants to take PrEP, we leave it up to them. But if it's required, the answer to that is no.
Yeah, thanks for that. Sister, we've got a question for you. So Rina says, thank you for your commitment and services provided by you and your team. How do we encourage more nurses to take on more specialized roles like the one you and your team have taken on for HIV services? So we have 5 HIV counselors, but I think we have a few more trained, but not really in HIV services, right? So is there an interest? And if there isn't, how do we encourage more?
Okay. We do have nurses who is interested in this field, but the thing is the quota for the post-basic that have given to PPUM at least 2 or 3 spaces for us. So what we do in-house training. In-house training as a CNE for the nurses, and we do seminars for nursing. Yearly we do that. So that is how we train our nurses.
Yeah, that's a great initiative, and hopefully more places will come up for us because we are really dependent on Ministry of Health opening up those quotas, right, for training. Yeah. Okay. I have a question for Pui Li. Where did that question go? Okay, so Dr. Aiman asked, I've been well informed about current HIV treatments and the success that goes along with it. I believe that people living with HIV shouldn't get any discrimination in any healthcare services, medical or dental. The problem is I noticed that a lot of my own colleagues show some level of discrimination in treating people living with HIV. How can I help them to not fear about HIV and not discriminate people living with HIV? After all, they are healthcare workers. So I think this is a theme that we've been talking about, but maybe some tips, Pui Li?
Thanks for your question, Ayman. So, well, really, I think in order to tackle stigma and discrimination in a healthcare setting, it can happen on many levels. On an individual level, so for example, it can start with you. So, if you are very well versed in the knowledge and the awareness, I think it's also it's an individual responsibility to kind of harp on about it and continue talking about it, the evidence behind it, and why your colleagues don't have to be fearful about it. So that awareness on an individual level, and also championing it, showing others. So practice what you preach, showing others that, there's nothing to be afraid of. Often I think we found that as a unit with other units, that has been a great way to slowly dispel the stigma and discrimination that happens. In other healthcare settings, it has to come from the institution. It has to be policy based. If an institution is able to say that we do not tolerate stigma and discrimination, and it's in a policy, I would think that the healthcare workers working in that institution will somehow have to figure out a way, challenging their beliefs to start dispelling the stigma and discrimination that they have towards people living with HIV. And also it has to be a hospital initiative and target to have continuous education, like what Sister Punita has mentioned. It can't be a one-off education once a year. It has to be continuous throughout a year, because what you're trying to do is you're trying to create behavioral change. So you need the buy-in of your hospital, of your institution, as well as find other people who are also champions for this, and band together and advocate to fight against stigma and discrimination for people living with HIV.
That's absolutely right. I think over the years, we have seen a lot of improvement in the way our healthcare workers treat our HIV patients, and it's setting an example as well. You mentioned about the stickers on the hazard stickers on every single possession of a HIV patient. I remember in those days, Prof. Adeeba, we used to go around and literally removed all these stickers, and Sashila is smiling over there. So and after just a year or two, we saw that no more stickers were being sticked everywhere. And having more medical officers rotating to ID, seeing how we treat our HIV patients have also changed. So from time to time, we do see some healthcare workers coming in with that huge discrimination with them, and it's probably also because they've never met a HIV patient. They've got all these preconceptions. So I think the more you know, the more you are exposed to them, the more we show how we treat our HIV patients. Hopefully, gradually we'll be able to overcome this. Okay, a question for Iskandar. Other than the continuous usage of the HART, antiretroviral therapy medication, are there any efforts being put in place with regards to curbing the HIV from spreading and growing, or to kill it, figuratively speaking? We talk about COVID and the vaccine coming out in 3 months, but HIV has been around for 30 years. So
Yeah, I love the question. So I think we need to appreciate also the amount of investment in HIV research that's been put into antiretroviral therapy, whilst concurrently looking at other agendas such as the HIV cure agenda, as well as HIV vaccines. I think a lot of the focus still remains on getting better and more tolerable treatments, although I think we're peaking at that. We've got very, very good treatments at the moment. We just need to be able to access it. So with dolutegravir or bictegravir integrase inhibitor-based regimens, I think we've sort of reaching the peak of where we are with HIV treatment in terms of how far we can go. And maybe getting down on a fewer number of drugs as opposed to 3 drugs down to 2 drugs is probably also gaining popularity. However, I think in terms of comparison with COVID, I mean, the COVID vaccine story has been amazing. You know, I mean, it's been short of amazing. I mean, there's no other word to describe it. 30 to 40,000 patients in each clinical trial. When the initial idea was generated, and to preliminary results. Yes, by press release initially, but then hopefully to be reviewed soon. And it's very unfortunate that the HIV vaccine story hasn't followed a very similar route, but it is a more difficult virus, and it's a more challenging virus. And there were very disappointing results from what was going to be a lot of hopes were going to be pinned on the South African vaccine trial this year, which did not show any success. But nevertheless, it's still worthwhile pursuing it. And I do think we will see a HIV vaccine in the end, and probably within 5 years. The HIV cure agenda is also going on very strong. And there are interested parties globally looking at this, and there have been stumbling blocks along the way. But once again, I think within 5 years, we should be able to see HIV cure. Do we need a cure when treatments are so successful? The answer is still yes. If you speak to any person living with HIV, ultimately we would like, any patient would like to take a drug that renders them to be able to get rid of the virus. And so they can stop treatment, very much like what we've done with hepatitis C.
Yeah, a lot of exciting things going on in the science of HIV medicine, isn't it? So I've got a question here from Jamal. My graph showed Malaysia has a stable rate of about 3,000 new diagnoses a year, despite existing initiatives like screening, IV drug users, pregnant women and premarital couples. What are the specific groups involved in this continued infection rate, and how can we reduce rates in this group? So I think that the second graph, which I just showed very, very briefly, showed that the reason why there's a plateau is because most of the cases are in the homosexual or men who have sex with men. And we are not seeing that many infection in the injecting drug users anymore. The other population that you were talking about, the premarital, pre-pregnancy thingy, they're not really key populations, so we were not expecting to see many cases there anyway. So the harm reduction measures taken in the early 2000s to reduce infection within IV drug users has resulted in a drop in infection within that population, and also within the whole population of Malaysia. But since now most infections are involving men who have sex with men, so as Iskandar has mentioned, other harm reduction or preventive measures need to be taken by the government, really. So implementing PrEP is one of them, so that we can reduce that graph further. So I think we still have a bit more time for one last questions. Again, I think it's probably for maybe for Iskandar again, sorry. As dynamics of transmission changes over the year, will PrEP be easily available or prescribed routinely to the key community, and what are the consequences we should be aware of or look forward to? I love that.
PrEP is already available. It's available within UMMC for those who feel that they are at risk of HIV. It is available within our unit, from the ID unit. It's available in private clinics. And if you want to look or get a directory, a national directory of PrEP providers, you can go to mypreplocator.com, which is a national web-based directory of PrEP providers that we worked with and sponsored by WHO in order to answer that persistent questions that we got about where can we access PrEP. So it gives you a comprehensive list of PrEP providers. So I think that was one of the questions. I forgot what the second question was. Sorry.
What consequences?
So
yeah.
the consequences of ongoing, so PrEP is something that you don't necessarily have to take on a daily basis, unlike antiretroviral treatment. You take it according to seasons of risk, and people go through seasons of risk throughout their life. They're not continuously at high risk of HIV infection, so you can start and stop it. And despite this, of starting and stop it, there's no increased risk of or concerns around the development of resistance. I think once again, the key issues around PrEP is it's because it's associated with concerns around that of what we call risk compensation, that there the possibility of increased risk-taking for people on PrEP. But what essentially PrEP does is just expand the options by which people can choose and the modality that they want to choose to prevent HIV. We no longer need to rely just on one prevention strategy, so condoms. We have PrEP, we have post-exposure prophylaxis, we have treatment as prevention. And as healthcare providers, what we're merely doing is just providing those options to those at risk. It is ultimately up to the person who feels or perceives himself to be at risk to choose which option is best for them.
Yeah. Okay, I think we are almost coming to the end of our session. Thank you very much to all of you. But before I end, I just need have a small advertisement to make. So World AIDS Day is on the 1st of December, but we have like a whole week of celebration for World AIDS Day. And the unit is also involved in another activity this weekend. So for those of you who have a free weekend this Saturday from 4 to 6:30, please tune in to our virtual public forum, which is themed Power to the Youth. Everyone is welcome. And you can get details of the forum when you log on to the Faculty of Medicine Facebook page. So do join us this Saturday from 4 to 6:30, and we'll be discussing other aspects of HIV care as well. So I think the message is quite clear. The science is there for us to get to zero, but we can see all the barriers that are there that might be hindering our efforts. I hope this short session this morning, with this short session, we were able to shed some light on the current situation of HIV epidemic in Malaysia, specifically looking at harm reduction and prevention of transmission, and also not forgetting looking at the additional barrier to getting to zero caused by stigma and discrimination against patients who have HIV. So it's an effort that needs to be put in by all of us, not just the ID unit or the HIV counselors, but everyone has a role to play to end AIDS by 2030, getting to zero new infections, zero discrimination, and zero AIDS-related death. So with this, I'd like to thank all my panelists again. Prof. Adeeba had to leave, unfortunately, 5 minutes earlier, but thank you so much, Iskandar, Pui Li, and also Sister Punita. And thank you to all my team who are also, in the background preparing for this forum. And also thank you to the faculty for supporting us with this forum. Thank you again for tuning in. We had almost 150 participants, which is great. Thank you so much for joining us, and happy World AIDS Day.